and I met, Al and I met in the summer of 1985 when he was Fred Epstein's chief resident at NYU on pediatric neurosurgery, and I was a hopeful medical student and rotated down with him. And Al was just a terrific mentor. The children loved him. It was clear that he was a natural pediatric neurosurgeon. He used to do magic tricks. It's pretty hard to upstage Fred Epstein, but Al would manage to do so. Anyway, so Al is just a brilliant surgeon, brilliant academic, and I'm sure we will. And also the famous recording artist who recorded medulloblastoma, "You Are My Bitch," and with that, I give you Dr. Cohen.
Thanks, Ron. A couple of things. Al, I hope it's okay if we record this. And I noticed there's a couple of things about Al. He started in medicine at Dartmouth after training in at Harvard and NYU. But anyway, I noticed that the medulloblastoma video, just like the halftime show, has been G-rated now and is called Extreme Medulloblastoma. But Al, please, pediatric brain tumors are your thing.
Guys, thank you very much. And I'm sorry for the technical glitches here starting. It's really an honor to be the speaker today at the IDMC. As you see, a number of old friends there. We go way back. I'm going to talk about some advances in the treatment of pediatric brain tumors. And I became interested in this a few years ago when I was at the Asian Congress of Neurological Surgery with Ron and Chris. I was in the men's room and I saw this sign because I became interested in precision medicine at this time, which said, please urinate with precision and elegance. And I don't know about you guys, but this has been an aspirational goal of mine ever since. And this is a talk that's going to be a little bit about precision medicine. But I wanted to start with the classical elements because, and by the way, are you able to hear me okay? Can you guys hear me?
Yes.
Yes, we can.
I just want to make sure. I have a problem with the video. I want to make sure I don't have a problem with the audio. But from the dawn of civilization, man has had an attempt to classify the universe here with earth, air, fire, and water. That was something that was used by the Greeks from pre-Socratic times up to the Middle Ages. This woman, matronly appearing, for those of you who don't recognize her, is Lucy Bailey Rourke, who was a dynamo of pediatric neuropathology at the Children's Hospital of Philadelphia. She's the person who categorized the primitive neuroactive dermal tumors. And she remarked about classification in her 1981 address to the American Association of Neuropathologists about how mammals are classified different from reptiles, but some of it's artificial. And she referred to in classification an ancient Chinese encyclopedia, the Celestial Emporium of Benevolent Knowledge, where the animal kingdom was classified into 14 different structures. And they included those that belong to the emperor, suckling pigs, stray dogs, those drawn with a very fine camel hair brush, those from a long way off that look like flies. So that was probably something that would be not really looked on highly by Linnaeus, who is the father of modern taxonomy, who created the binomial system, genus, species, Homo sapiens, that's still in use now, famous botanists and zoologists. But I got interested in this talk when the WHO introduced CNS5, the fifth categorization of classification of tumors of the central nervous system. This started in 1979. And it's a hybrid system because previously this system was based more on histology and immunohistochemistry, ultrastructure, but now it's hybrid because of major advances in molecular biomarkers. And I think that there are important advances and problems with this system, but in one sense, the molecular biologists and the clinicians are not speaking to each other. So I thought I would use this as a backbone to review what's going on in pediatric brain tumors. In the WHO CNS5, one thing is the entity term has been replaced by type, variant replaced by subtype. And that's just to make these synchronous with what's going on in other tumor types in the blue books. Roman numerals were replaced by Arabic numerals because there was some confusion where these Roman numerals could be misunderstood. And next generation sequencing, high throughput next generation sequencing, looking at methylomic profiles, has been used to help in the diagnosis and treatment, looking for new targeted therapies in this treatment. But the trade-off is that some of the names now, we had lived in the era of Ron and Chris and I, where we had a meningioma or a glioma. Some of the names now are lengthy and cumbersome. Diffuse pediatric type high-grade glioma, H3 wild type and IDH wild type, or desmoplastic myxoid neoplasm of the pineal region, SMARCB1 mutant. These are the new names. There are 22 new names of pediatric of brain tumors in this new classification, and many of them, like these, don't roll easily off the tongue. Pediatric brain tumors are the most common solid tumors in children. They're the leading cause of cancer death in this group. 20% of CNS tumors of childhood, they account for 20% of childhood malignancies, and second only to leukemia in frequency. Advances in pediatric brain tumors have led to improved survival and quality of life for some, but the prognosis for others remains dismal. As you can see, cure often comes with a cost, and here is the survival curve for glioblastoma over the years. So there's still a lot of work to be done. And for some, they harbor long-term sequelae from treatment, like radiation-induced vasculitis. And this is an important problem in pediatric neurosurgery. So in terms of epidemiology, there's really only one factor that's been associated with the risk of pediatric brain tumors, and that's ionizing radiation. There have been some studies on atopic conditions showing that it can decrease the risk, but there are some conflicting work, and that's still being evaluated. In terms of the history of brain tumor surgery, this is in Jefferson Hospital. This was in the 1880s. This is W.W. Keene, William Williams Keene, performed one of the first brain tumor operations, removing a meningioma in December 15th, 1888. But primacy was given to this man, Rickman Godley, working in London, and he worked in this hospital for epilepsy and paralysis in Regent Square in London. It was a 3-story building that was subsequently torn down, moved to Maida Vale, and he did an operation on a Scottish farmer. It was diagnosed by Hughes Bennett. They wrote this up in the British Medical Journal. In 1884, they did this surgery, and the patient had seizures that were referred to the right hemisphere. This was based on neurologic exam alone. Here they identified with lines the site of the Rolandic fissure, and this was the resection that they performed. They did this operation under chloroform anesthesia. Godley was the nephew of Joseph Lister, the father of antiseptic surgery, and they used carbolic acid to prep the patient. Here is Godley operating a little bit later, but this operation was done in 1884, and it was a 2-hour operation for removal of a glioma. And the operation was considered a success, but 4 days later, there was a purulent smell from the wound. The brain began fungating out of the head, and 28 days after the operation, the patient died of a seizure and an infection. And so it was not really a wonderful operation, but it was a landmark operation because it's considered the first resection of a primary tumor of the brain. Godley went on to write a biography of his uncle, Joseph Lister. He became knighted by the Queen. But anybody recognize this guy? Because primacy for brain tumor surgery really goes to him. And this is William McEwen, who was born in the Firth of Clyde in Scotland. And he did the first brain tumor resection in 1879. Years earlier, he had done some brain abscesses before. The patient was Barbara Watson, and this was a note that he made in his personal journal. And she was a 14-year-old girl who had presented with seizures and intellectual impairment. I found this picture of her. in her postoperative years. He had operated on her a year earlier for a subcutaneous tumor above the orbit. But on the basis of her presentation with seizures, he identified a lesion, irritative lesion in the left frontal lobe adjacent to the motor strip. And he did an operation with a trephine, again under chloroform anesthesia. And here he is operating a little bit later. But this was the first successful operation. Here is McEwen operating. He was a rambunctious guy. The operation was successful. He published this in the British Medical Journal. And here was his diagram of where the tumor was located. He noted that the prior surgeons were unsuccessful because the brain was little understood. It was a mysterious dome of thought, and said that the brain was a dark continent that could only be entered by groping in the dark. And he attributed his success to two things. One was he was a student of Lister, so he used antiseptic technique. He boiled his instruments, and he prepped with soap, water, turpentine, methylated spirits, and what was in vogue, carbolic acid. And the other was localization that he learned from these neurologists, the eminent neurologists at the time, because this was before CT or MRI. His patient survived. She lived for 8 years, and she died later of glomerulonephritis. It was a successful operation. He's been little credited for this because he lived in the shadow of the people in London. Here's McEwen later in life. He became the Regius Professor of Surgery. He was knighted by the Queen. He was actually offered the job of chair of the Department of Surgery at my institution, Johns Hopkins, but he refused because they wouldn't allow him to have control over the nurses in the operating room. And he went on to his last book was The Growth and Shedding of the Antlers of the Deer. He was kind of a Renaissance man that he wrote before he died. Here he is a year before death as the Regius Professor of Surgery. So McEwen, the first operation for a brain tumor was done by William McEwen in Scotland in 1879, and the patient was a 14-year-old girl.
What?
What? Now, I wanted to mention a little bit about the clinical presentation because it's different in kids. Infants are pre-verbal, so we can't really take a good history about headache, but we can see macrocephaly, tense fontanelles, sunset eyes, sometimes loss of milestone. Here you can see sunset eyes in the kid with a big head with a brain tumor. There is a diencephalic syndrome where patients have failure to thrive, weight loss, emaciation in the setting of normal caloric intake. And that can be associated with a tumor of the hypothalamus or thalamus. But a lot of the symptoms of irritability, weight loss, vomiting in infants are caused by other conditions than brain tumors. In older children and toddlers, we can see papilledema and sixth nerve palsy. Sixth nerve palsy can be a false localizing sign because of the length of the nerve in the head. In young children, the location varies with age. Under 3 years, the tumors tend to be supratentorial, then from 4 to 10, infratentorial, and then older than 10, more likely to be supratentorial again. And supratentorial tumors can present with headache and seizure or focal signs, depending on the location. This is a kid that I cared for with a dysumbroplastic neuroepithelial tumor presented with seizures and has this soapy appearance on MRI. Seizures are the presenting sign in pediatric brain tumors in 13% of the cases, but seizures as a cause of brain tumors are rare. Only 1 to 3% of kids who have seizures actually really have a brain tumor. It's a rare finding. When the tumors are in the suprasellar region, they can involve the optic apparatus and hypothalamus. This was an 18-month-old girl who came to us with precocious puberty, and we removed this lesion, which was a hypothalamic hamartoma, and arrested her precocious puberty. But you can also see endocrinopathies and other types of seizures, gelastic seizures, uncontrolled laughing, or dichristic seizures, uncontrolled crying in these kids. So the presentation of pediatric tumors is different from adults. And for those infratentorial, we see nausea, vomiting, headache, ataxia, papilledema. Here we're removing a pilomyxoid astrocytoma. This is the kid with bilateral facial palsy involving the fourth ventral and brainstem. Your rostral is this way and caudal is this way. Here's the tumor. Wanted to say a word about neuroimaging. It's changed the field of neurosurgery, in particular pediatric neurosurgery. because of advances in the technique of imaging. But it comes with an important lesson about the detail. And here's a $50 million gift for USC, a neuroimaging center. And it's the little things that get you in trouble, because if you look, this poor artist forgot and put the brain in backwards. Here's the brain. And so again, in art and in neurosurgery, it's the little things that can get you in big trouble. But imaging makes a big difference. This is a patient of mine, an 8-year-old girl who presented with, she had diabetes insipidus and visual loss. And what we can see, the standard workup of a kid with a brain tumor is an MRI without and with contrast. You can see this big contrast enhancing supracellular mass that's eroding down the clivus in this girl. This was a unique case in which we were able to treat the patient without surgery, without even a biopsy, on the basis of biomarkers. Her beta HCG was slightly elevated in the serum and CSF, and there's a synchronous lesion here and in the pineal area. So the presumptive diagnosis was a germ cell tumor. We were able to treat her with on a protocol with chemotherapy and radiation without even a biopsy, and the tumor melted. But I'm using this as an introduction because of the advances in neuroimaging. Here we have the susceptibility weighted imaging, this young child with an atypical teratoid rhabdoid tumor, a highly aggressive lethal tumor of infancy. And you can see here on the SWI, the hemorrhage in the tumor. Diffusion weighted imaging looks at the dispersion of water and is usually bright on highly cellular aggressive tumors, but also on epidermoid tumors. This can be a sign, and these are benign tumors, but we look at diffusion weighted imaging and diffusion tensor imaging to look at fiber tracts to help plan surgery. Functional MRI, we don't use that often in surgery. This is a child of mine who had an infiltrating lesion in the dominant temporal lobe, a teenager. We don't use it that often because kids are not always that cooperative. In fact, this kid was 17 years old, tried to get up out of the pins during the event, but it can be helpful in helping to protect eloquent brain. And MR spectroscopy can do some really cool things. This is a normal spectroscopy, but N-acetyl aspartate is a neuronal marker. Choline is a cell membrane marker. In general, tumors have an elevated choline and a depressed NAA, but myoinositol can be seen in ependymomas and choroid plexus tumors, taurine in medulloblastomas, but it hasn't really made a major change in the way we practice. And then surgical considerations. There are advances in surgical technique that have helped enormously. One is the intraoperative MRI. It's a great tool, but as the saying goes, a fool with a tool is still a fool, but it is a really cool tool. And what in pediatric neurosurgery can be useful for finding tumors that be hidden behind some brain, or eliminating the need for a anesthetic controlled postoperative scan. It's an expensive tool, it takes longer, but it's made advances. Image guided surgery with frameless stereotactic navigation helps localize the lesions. Fluorescence guided surgery with 5-ALA, a protoporphyrin. He was lighting up this oligodendroglioma in the frontal lobe. And we've been using tazulariside as part of the Pacific Pediatric Neuro-Oncology Consortium. This is a near-infrared imaging agent. It's an analog, a synthetic analog of chlorotoxin, which is the venom of the Israeli death stalker scorpion. And it's conjugated to indocyanine green. It lights up tumors. It's a synthetic, and here's the smiling face of this death stalker. It reminded me a little bit of our former Attorney General, William P. Barr, if you look at that similarity there. And this is what it does. Here's a posterior fossa astrocytoma. It lights up, the surrounding brain does it. So this is being investigated as another fluorescence guided aid for surgery. We have minimally invasive neurosurgery and techniques we can look right through you. The microscope has made a major advance. We have endoscopes, exoscopes, and here we have an endoscopic resection of a colloid cyst in the third ventricle working underwater. If you can see the lesion, you can do things with miniaturized instruments. And then at this point, I just wanted to go over some representative pediatric brain tumors. And the field is so vast that I wanted to just limit what I was going to say to gliomas and embryonal tumors. This is an ependymoma, an aggressive ependymoma in the midline posterior fossa of a young child. But low-grade gliomas are the most frequent brain tumor of childhood. In adults, we see the glioblastoma, but the most frequent supratentorial tumor of childhood is low-grade glioma. This is a 5-month-old infant patient of mine who presented with dancing eye movements. And he had this tumor that we treated endoscopically, decompressed, and have managed him with chemotherapy. He has been stabilized by that. He presented this dancing eye movement presentation with spasmus mutans, which is an unusual form of a lesion, not always associated with tumors, but in the suprasellar region here. And in general, the treatment for pediatric low-grade gliomas is surgical to establish a diagnosis and a maximal safe resection. That's not possible for tumors that infiltrate the optic pathways, but in general, that's what we do. And here's a case of a patient who presented with seizures and had a low-grade glioma here. And we wrote this as a profile of the glioma because it has imprinted itself under the surface of the skull. You can see the vessel here and the tumor on either side. This was a pilocytic astrocytoma. Pediatric low-grade gliomas in an international study by Stockman had a 5-year progression-free survival of 69% and an overall survival of 95%. Risk factors being young age, incomplete resection, fibrillary histology, and hypothalamic location. Now, pediatric brain tumors are different from adults, and temozolomide has been effective in adult low-grade gliomas, but it's been less clear in pediatric low-grade gliomas. There are some studies showing an effect, but in general, it has not had the same effectiveness as it has in adults. Bevacizumab, avastatin, has been used as salvage therapy for recurrent low-grade gliomas, and it can give rapid control of tumor progression, but it can have side effects, and when it's stopped, the tumor can continue to go. And that's both with other chemotherapeutic agents and not. And a big advance in pediatric low-grade gliomas is the understanding of the mitogen-activated protein kinase pathway, the signaling pathway that's associated with the majority of the low-grade gliomas. Alterations in this pathway, including BRAF, an oncogene mutation or fusion, NF1, fibroblast growth factor receptor 1, and neurotrophic receptor kinase family fusions. The message comes from the cell surface to the nucleus, and BRAF, when it's mutated, causes the mitogen-activated pathway to grow out of control. Here again, the growth factor coming from the cell surface. And these RAS, RAF, MEK, ERK pathways, the names are difficult to remember, but activation of BRAF from a mutation causes constitutive signaling of this pathway and tumorigenesis. And because of that, these low-grade tumors, the alteration in the BRAF gene encodes the serine threonine kinase protein, which is a downstream regulator of MAP kinase. And there have been attempts to target this mutation. And here's an example of using dabrafenib, which is an inhibitor of BRAF on this posterior fossa tumor before and 8 weeks after. And we're looking now, because of the toxicity of radiation and chemotherapy in kids, for targeted therapy. And that's one of the advances of this WHO CNS5 system, where the names are bulky, but the molecular analysis enables targeting. So BRAF, this oncogene, has a mutation, which we talked about, but there's also a BRAF fusion with KIAA 1549. And this is on chromosome band 7q34, where BRAF is located. And the important here is that this BRAF fusion is the most common abnormality seen in pilocytic astrocytomas. Here's a pilocytic astrocytoma with very astrocytes and this benign background. The pilocytic astrocytoma is the most common astrocytoma of childhood. It accounts for 20% of brain tumors in children under the age of 20 years. This is a teenager who had headaches and this cystic and solid pilocytic astrocytoma of the temporal lobe. And the importance is that the BRAF fusion can be targeted as well. And one of the drugs is selumetinib, which is a MEK inhibitor. And there are studies in which selumetinib can improve the survival of patients with pilocytic astrocytomas. There was a phase 2 trial that's being evaluated in several phase 3 trials right now, and it's shown effectiveness. There are some genetically determined low-grade gliomas associated with neurocutaneous syndromes like neurofibromatosis 1 and tuberous sclerosis and Noonan syndrome. Here are the malar angiofibromas that we can see in tuberous sclerosis. This is a 12-year-old boy who presented with headaches. He had NF1 in this tumor in the ventricle, which we removed through a transcolloidal approach. And NF1 can activate the signaling pathway in the MAPK signaling pathway and is associated with it. So there are ways that we can control this again with tumor inhibitors of the MAP kinase pathway, but this was removed by surgery. Tuberous sclerosis is from the TSC1 and 2 genes, and we removed this through a transcallosal approach as a patient who had tuberous sclerosis. And for lesions that can't be resected, there are the mTOR inhibitors, the mammalian rapamycin, the tumor inhibitors. They work, but they can have side effects. Some of the side effects can be related to the immunosuppression, and the tumors will grow when the drug is stopped. And Noonan syndrome, which is considered a RASopathy, can be associated with gliomas. This was a patient of mine who presented with seizures, had this disembryoplastic neuroepithelial tumor. Noonan syndrome, the kids have short stature and cardiac disorders. They can have hematologic disorders, as this kid did, which can make the surgery a little bit exciting. He had hemophilia as well, but it's a RASopathy, and it's related to several mutations in the MAP kinase pathway. So that's low-grade gliomas in a nutshell. High-grade gliomas are a tough problem. They represent 10% of pediatric brain tumors. The prognosis is poor. Here you can see what was formerly called the DIPG, the diffuse intrinsic pontine glioma surrounding the basilar artery. This is a uniformly lethal tumor. But the term glioblastoma has undergone an interesting change. This was a tumor described by Cushing and Bailey in 1926, and it subsequently went from spongioblastoma to glioblastoma multiforme. Then the term multiforme was dropped, and now glioblastoma is no longer a term in the lexicon describing pediatric brain tumors. A glioblastoma is now narrowly described as a type of adult wild type glial tumor, high-grade glial tumor with other associated features, including hypercellularity or TERT promoter mutations or loss of chromosome 7 or gain of 10. There's various things, but the pediatric glioblastoma, the nomenclature has changed dramatically, is not used in kids. That's one of the new things in CNS5. But in terms of high-grade gliomas, there's been an interesting advance on the basis of histones. And this was done in 2012. These beads on a string, histones, are, this is an epigenetic mechanism. That is, it doesn't interfere with the mutation of DNA, but with the structure. And by altering the structure of DNA, what histones do normally is to compact DNA so that they get it. But some of these histones can be targeted. We have 4 types of these high-grade gliomas in kids. And the first is the DMG, the diffuse midline glioma. The diffuse intrinsic pontine glioma, which is this example of, is now called the diffuse midline glioma H3K27 altered. It used to be H3K27 mutated, but now there are some different events that are in H3K27. But the understanding of that has enabled various targeted therapies for these tumors. This is a highly lethal tumor that's in the midline, as you can see here in this patient with a pontine lesion. There's another type of high-grade glioma called the H3G34 mutant. And this has to do with substitutions of amino acids in different places. This tumor is more likely in the cerebral hemispheres, also an aggressive tumor, but also one that can be targeted with therapy. A third type is, again, this doesn't roll easily off the tongue, the diffuse pediatric type high-grade glioma, H3 wild type, and IDH wild type. You can see this was a 10-year-old boy with this very large tumor that subsequently went bilaterally. And it's interesting, the adult high-grade gliomas can have 1p19q co-deletions or IDH 1 and 2 mutations. That's less common in pediatric brain tumors. Again, a third type. And the problem is, again, the language that the molecular biologists speak is different from what we see clinically, but these lesions can be targeted. And although we don't have a pediatric glioblastoma, this is the fourth type of high-grade glioma in children, and it's infant-type hemispheric glioma. This is a 7-month-old child with this very large tumor, and these can have kinase fusions. And the importance of these kinase fusions is that they can be targeted. This child was treated with debulking surgery and targeted therapy. So once again, temozolomide, which has made advances in the treatment of adult high-grade gliomas, the addition of this is better than just radiotherapy alone, has not had the same effect in kids. There have been studies where it's worked. It's something that people feel may be related to methylguanine methyltransferase. And by adding another drug, lomustine, to this, it seems to work a little bit better, but the results of temozolomide in kids have not been equal to what they are in adults. Another difference between pediatric and adult gliomas. And so there's this interest in targeted therapy, but it is unfortunate that the median survival, the overall survival for pediatric high-grade gliomas is terrible. And even with radiation therapy, diffuse midline glioma has a survival of between 8 and 11 months. So what we're doing right now may help a little, but there's a long way to go. So one of the things that's been used is histone deacetylase inhibitors. Again, the histone gene compacts the DNA to fit in the nucleus, and by breaking this up, we can reverse the transcription of this. And so one of the drugs is panobinostat, and that can have an effect on some of these high-grade gliomas. We're studying fimobinostat, another HDAC inhibitor. Again, these work by epigenetic mechanisms, not by altering the mutation of the DNA, but by changing its conformation. Another drug that's being explored in high-grade gliomas in pediatric patients is ONC201, which is a dopamine antagonist, and it's had some effect on gliomas. And two more things I wanted to talk about. One, ependymal tumors. These tumors are the third most common brain tumor of childhood. They account for 5% of central nervous system neoplasms and represent 2/3 of the intracranial ependymomas in the posterior fossa. 2/3 of these are in the posterior fossa. You can see this is a malignant ependymoma, and these are pseudo rosettes around the blood vessel. So this is the myxopapillary ependymoma, a patient who presented with back pain and leg weakness. Myxopapillary ependymoma of the phylum Terminale. This used to be considered a grade 1 tumor. In the new classification, it's considered grade 2 because it behaves more like some of the spinal cord ependymomas. But the grade 2 and 3 ependymomas now have also been recategorized. The subependymoma, a relatively indolent tumor, is still considered grade 1. But the grade 2 and 3 tumors are separated by location, supratentorial and infratentorial. And this gets to be a little confusing, but there are two general types of supratentorial ependymomas. One is considered the Raleigh fusion and the other is the YAP fusion. The Raleigh fusion, or the C11ORF95 Raleigh fusion, accounts for 70% of the supratentorial tumors. The YAP fusion, the yes-associated protein, the rest or most of the rest. And again, because this is an ever-changing field, the Raleigh term now has been replaced by ZIFTA. The ZIFTA fusion is used because ZIFTA can fuse with more structures than Raleigh. It's felt to be more accurate. In the past, or up to recently, it's the Raleigh or ZIFTA fusion was felt to be more aggressive. It tends to occur in younger children off the midline with a poorer survival. But a recent study by the Children's Oncology Group found that with the addition of conformal radiation, the difference in survival between the two groups is really not that much. And so again, this is a changing field, but we call supratentorial ependymomas rarely or ZIP diffusion or YAP fusion. And to add to the confusion, the posterior fossa tumors are now called posterior fossa A and B based on methylomic profiling of the lesion. In general, the posterior fossa A tumors are more lateral. They're felt to be more aggressive. They tend to occur in younger children. This is a posterior fossa A ependymoma that we resected. But again, in a recent study with children receiving now, even at a young age, conformal radiation therapy, the difference in survival between posterior fossa A and B seems to have gone away. So the treatment for ependymomas is maximal safe resection and radiation therapy. Chemotherapy has not made a major advance in the treatment of ependymomas, although there are studies in which it seems to be helping. It's being continuously evaluated. But the overall survival of these tumors, the 10-year overall survival is still less than 50%. And so there's much work to be done, and hopefully some work on mutation-directed targeted therapy. The last group of tumors I wanted to talk about are the CNS embryonal tumors. And the one that we all recognize is medulloblastoma. Others include the atypical teratoid rhabdoid tumor, the embryonal tumor with multi-layered results, ETMR. Again, these names don't roll easily off the tongue. CNS neuroblastoma, FOXR2 activated, and CNS tumor with B-core internal tandem duplication. The advantage is that we're hoping that these will be things that can be targeted. The disadvantage is you need a textbook to be able to remember these. But medulloblastoma is the most common malignant tumor of childhood. It accounts for 60% of childhood embryonal tumors. 70% of the kids are under the age of 10, and a third of these are in children under the age of 3. This is a classic ependymoma. Usually these enhance more in the posterior fossa. They tend to rise from the inferior medullary velum of the fourth ventricle. And once again, Cushing and Bailey described this in 1925 in their article about medulloblastoma cerebelli, a small round blue cell tumor. It was interesting that that term is still in use, even though there has never been a cell identified as the medulloblast. But the CNS5 now identifies medulloblastoma. The nomenclature has changed into 2 categories. One is histologically defined, and one is molecularly defined. These are small round blue cell tumors. They used to be called PNETs, primitive neuroectodermal tumors, by Lucy Rourke. That has now been thrown out. Scott Pomeroy and others have identified that these tumors have different substructures. And so the term PNET has now been replaced by embryonal tumor, and medulloblastoma, histologically and molecularly defined. The old histologically defined include classic desmoplastic nodular, extensive nodularity, and large cell anaplastic. It's a lot of factoids going on here, but in that scheme, the desmoplastic nodular and extensive nodularity, these nodularity tumors, tended to have a better prognosis. But now, on the molecular level, the medulloblastoma has now been identified. There are at least 4 different subtypes. And that's even changed from when Mike Taylor and Scott Pomeroy first identified these. Now, according to CNS5, there are 4 molecular subtypes of medulloblastoma. One is the Wnt or wingless activated, sonic hedgehog activated with TP53 wild type, sonic hedgehog with TP53 mutant. That's associated with a poorer prognosis. And the Wnt, non-Wnt and non-sonic hedgehog activated. These used to be called group 3 and 4. That's how rapidly this field is changing. Here are some examples of the subgroups of medulloblastoma. This is the wingless or Wnt. It tends to occur laterally. It's very vascular. It's got the best prognosis. There's a sonic hedgehog that can occur in the cerebellar hemisphere, and it's a more heterogeneous tumor. And the non-Wnt, non-sonic hedgehog tends to be in the midline. These two affect boys and girls equally. This one can be in young kids and older. It tends to be in the midline, and boys are affected much more than girls. This often has mutations at the time of presentation. This is a table from Michael Taylor, who did a lot of the original work on this. I don't know whether you can see my screen, but this is the wingless or the Wnt tumor. and it tends to be uncommon. It accounts for 10% of medulloblastomas. The majority are group 4, group 3 and 4, and it has rare metastasis.
We'll leave.
Please mute.
Because I just want to dial in so I can still have the
Someone
audio.
mute,
Because as soon as we leave this Wi-Fi, it's gonna turn to shit.
Somebody's
Everybody mute, please.
Thank you. This is the more rare tumor, but it has the best prognosis, over 95% survival. It's very vascular, and it can occur often in the peduncle and laterally as well. The sonic hedgehog can be lateral in the cerebellar hemispheres. It has some mutations and amplifications. The group 3 and 4 are now both called non-sonic hedgehog. They can have metastases at the time of presentation. The survival, the 5-year survival of these is between 50 and 70%. They're more aggressive tumors. Just a couple of words about these tumors. This is the Wnt or wingless activated. It is associated with the excess production of beta-catenin in the cell nucleus, which drives tumorigenesis. There are fenestrations in the blood vessels of the Wnt tumor, which is why they can sometimes present with hemorrhage. But maybe that's the reason that they also tend to do better. The chemotherapy can access the tumors better, but it's about a 97% overall survival with the wingless variant, although it only accounts for 10% of the tumors. The sonic hedgehog activated tumors, again, are in the hemisphere. This is a kid who had headache and vomiting, this big tumor coming out of the head. And this can be associated with mutations of the patched 1 gene and the SMO or smoothened gene, which can be targeted. These are more heterogeneous. The survival is not as good as that for the Wnt tumors. And this is a non-Wnt, non-sonic hedgehog, formerly called either group 3 or 4. These are tumors in the midline. This one was in a kid who presented with hemorrhage. Hemorrhage is more common in the Wnt tumor, but the Wnt is less common overall. These tumors can more likely have metastases at the time of diagnosis. Treatment is a combination of radiation and chemotherapy. The overall survival is not as good. And then there are some hereditary predisposition tumors that occur with medulloblastoma. The Wnt is associated with the Turcotte syndrome, sonic hedgehog with Gorlin or Leaf-Romany syndrome. And this is Turcotte syndrome, and this can be associated. This is adenomatous polyposis coli syndrome, and the APC gene is seen in the Wnt tumors, and again, something that can be targeted. Gorlin syndrome, the nevoid basal cell carcinoma syndrome, is associated with the patched 1 gene that can be mutated, and that's associated with sonic hedgehog tumors, sonic hedgehog medulloblastomas. They also get these keratocystic tumors of the jaw. And Leaf-Romany syndrome, which is a TP53 aggressive tumor syndrome, can be associated with the sonic hedgehog variant of medulloblastoma. So the treatment of medulloblastoma has undergone major advances over the years. This was Ingram and Matson, the legendary founders of pediatric neurosurgery at Boston Children's Hospital. And in their classic textbook, The Neurosurgery of Infancy and Childhood in 1954, they wrote, "To our knowledge, no patient with this lesion has ever been cured, and it seems unlikely that one ever will be with our present therapeutic methods." That was also repeated in their second edition in 1961. Ingram had a penchant for the astrocyte. It was on the cover of his book. He gave his residents a tie with an astrocyte on it, and he had astrocytes on the china in his office. But that was the state of affairs from these pioneers in pediatric neurosurgery, and that is fortunately no longer the case. The conventional treatment for medulloblastoma is maximal safe resection and craniospinal radiation and chemotherapy. And the overall survival, the overall 5-year survival for medulloblastoma, once uniformly fatal, is now over 70%. But more importantly, now that we have WHO CNS5, the ability to look at these tumors on a molecular level, and they're subcategorized even more than what I've gone over with you here today, we can use targeted therapy, and in selected cases, like the Wnt, we can get a survival rate of up to 95%. And so the future advances now are looking at de-escalation for the treatment of the WIT, since it tends to do so well, and targeted therapy for the sonic hedgehog tumors with therapy directed at smoothened and its downstream pathways, and risk-adjusted therapy for the non-WIT, non-sonic hedgehog tumors. But targeted therapy is going to be the future for the management of these tumors. And in summary, for the management of pediatric brain tumors, the field has changed dramatically over the years, and even CNS5, which I'm still having trouble coming to grips with, is just an evolution of nomenclature that's going to change rapidly. But the survival for children with pediatric brain tumors has improved dramatically, and kids who were dying of these lesions in the past can now survive and live a useful life. But the effects of chemotherapy and radiation still impact the quality of survival for these children. And I think the advances in targeted therapy, although they've been modest to date, will be the future and will be able to advance and improve the survival overall and progression-free of pediatric brain tumors and mitigate the long-term consequences, which remain substantial. And so that, in a nutshell, is pediatric brain tumors. I'm going to stop and see if anybody has any questions or comments.
Al, that was great. Are there comments, questions we could have?
Yeah, this is Raphael. I really enjoyed your talk, and it was really nice to go through everything. I might have missed it, but what's your thoughts of like the CED and DIPG, future as far as like some of the work being done in Cornell?
Yeah, so that's, and the problem is this is such an enormous field that I could only do a biopsy of a small part of it. But this convection enhanced delivery, immunotherapy, particularly for DIPG, is a way to get the medication to the tumor. And that's being investigated at Cornell and other places. And I think that is going to have a role. Immunotherapy, CAR T-cell therapy, all these things are being explored. So far, they have not made a major advance in the outcome of these tumors. These are highly aggressive tumors. And again, probably the DIPG, one of the most aggressive tumors that we deal with, uniformly lethal. The ATRT, the atypical teratoid rhabdoid tumor. Again, I think the treatment is going to be techniques like this, convection enhanced delivery, targeted therapy. But to date, even with these fancy techniques, even with this new nomenclature, the results have been limited, not substantial. This is kind of a factoid type talk, and I didn't want to overwhelm you. I don't know Chris and Ronnie. I do have my video of I made a video about medulloblastoma, but it's kind of PG-13, maybe NC-17. If you want, I can show it, but I don't want to offend anybody.
No, you're not going to offend anybody. Anyone who might be offended, you can log on. But no, your videos are so entertaining and educational that by all means, people have to have a sense of humor.
Well, I didn't want to overwhelm you with a bunch of factoids, so I did look at literature search and found that there was really no video on medulloblastoma, again, the most common malignant tumor of childhood. So I got together with some of my patients, and they got permission from their family because I felt that I'm a pediatric nurse, and I felt that rap was really my genre. And I got permission, rap has to have a little bit of an edge, so they got permission from their family, and we made this video with some of my patients as a teaching tool for medulloblastoma. I hope this will play.
We're talking about.
Can you hear that? Were you able to hear that?
Yes, we can.
Yep.
Okay, just want to make sure you can hear.
We're talking about the malignant pediatric brain tumor medulloblastoma with our renowned expert, Dr. Alan Cohen, who, according to his own resume, is considered to be the leading brain surgeon in the entire world. Now, Dr. Cohen, I understand that you've described battling and operating on malignant brain tumors as a street fight. And I understand that you have some unique ways to involve your patients in the surgical procedure. Actually, I see that you brought some of them with you today. Now, I'd like to find out a little bit more about that. I'd like to know what your operating room is like. I hear it's a bit unconventional.
Trust me, dude, you don't want to know.
Yeah, this dude is crazy.
I popped the skull cap with a power tool, so don't give me no crap. I had some medical school. Then I pimped the operation without causing a glitch, and I say, medulloblastoma, you are my bitch. I tell all my players now, don't you be hating, just use the bipolar forceps for coagulating. Then I tent the wankendura with a thin braided stitch, and I say, medulloblastoma, you are my bitch.
Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch.
The music ain't mine, they're playing honka-tonk, but the operation's fine like donk. When I smell the rank aroma, then my head begins to twitch, and I say, medulloblastoma, you are my bitch.
Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch.
Whoa, that is a real shocker. That is some real behind-the-scenes footage. Tell me, doctor, what is the most important instrument you use in the OR?
I'll have to go with the stereotactic navigation, Vic.
No question.
To spank the ghetto tumor takes some innovation, so I crank the frameless stereotactic navigation. If you try not to jerk, I'll let you handle the guns, but if you're going berserk, please don't be grabbing my buns.
He's going berserk, don't be grabbing his buns. If he's going berserk, don't be grabbing his buns.
When they ask me where to aim, I gotta get down and tell them that I'm directing my flame right at the medullary velum. It's a ganglioglioma with a chromosomal switch, and I say, medulloblastoma, you are my bitch.
Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch.
If cerebellar swelling should turn into a factor, then my mamas all start yelling and I loosen my retractor, cause the posterior fossa is my gangster niche, and I say, medulloblastoma, you are my bitch.
Whoa, I think he might be scaring some of our viewers. I had no idea this is what went on in the operating room. I thought you worked quietly and meticulously under the high magnification guidance of your operating microscope.
You're clueless, dude.
Once I roll in the scope, my homies all will agree that I'm unable to cope without a shot of Dom P. So I tighten up my booty in my surgical gown because on my tour of duty, that old skank's going down.
On his tour of duty, that skank's going down. On his tour of duty, that skank's going down.
I'll vaporize the tumor with a laser beam, and then I lock it down and have myself a Krispy Kreme. I got a big fat diploma, but it never made me rich, and I say, medulloblastoma, you are my bitch.
Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch.
I can show you my bling because I got me some class, but if you mess with the king, I'll bust a cap in your ass. By now my posse's kicking at a fever pitch, and I say, medulloblastoma, you are my bitch.
Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch.
When the tumor's in the bucket and it's felt my abuse, then I tell my crunks to chuck it and I chunk up the deuce. I say we're all in the groove, so please announce if you would that I'll be busting a move before I bounce in the hood.
He'll be busting a move before he bounces in the hood. He'll be busting a move before he bounces in the hood.
One final question, doctor. Biggie or Tupac? Be honest here.
Man, what? Man, I'm about to whack this dude, man.
Hey, what? You can't get away from me.
When they cried we can't close, I just sat back and laughed. I said, let me propose we use a fat dural graft. So I stopped the attack because the tumor's been slain, and I grab my Buddha sack and start to seal up the brain.
And he grabs his booty sack and he seals up the brain. He grabs his booty sack and he seals up the brain.
Then I put back the bone and we all chill to Count Basie. So won't you pick up the phone and get me Benjamin Casey? He say, what the dealio, my brother? Which end is which? And I say, medulloblastoma, you are my bitch.
Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch. Medulloblastoma, you are my bitch.
We're talking.
Whoops. Well, anybody have any questions? If anybody logged in late, you may be wondering about this.
I love it. Al, thank you so much. As usual, not only entertaining, but incredibly educational. And now all our residents are going to rotate with you, but we'll look forward to seeing you at our next get together.
Yeah, thanks so much, guys. It's great to see you all. It was an honor to be part of the group. Thanks so much.
See you later, Al. Thank you so much.
Thank you. So long.